Good morning, my name is Dr. Jo Maybin. I'm very pleased that you've clicked on our presentation where I will present findings from a review that we conducted of a test and learn of the Buurtzorg model of care in West Suffolk. I'm presenting on behalf of a small team from the King's Fund, including Matthew Honeyman, Ethan Williams and Susie Perks-Baker. The King's Fund is a charity based in London working to improve health and care in England. So I will cover a little bit about what the Buurtzorg model is, how the West Suffolk test and learn came about, the purpose and methods of this review, and some headline achievements and challenges in the findings of our review, and some of the implications that we took from this. The Buurtzorg model of care was established in the Netherlands in 2006 by Jos de Blok, a district nurse, an experienced manager and an entrepreneur, working with some other colleagues to find a way to try to reconnect nursing and the people being cared for. Humanity over bureaucracy was the slogan, and an attention to providing small teams who would serve neighbourhoods. Buurtzorg means neighbourhood in English. And these teams would provide care for people in their own homes. It would be health and social care, and it would be focused on intense care at the beginning around supporting a person to regain their independence, including through connecting them to informal networks of support as well as other statutory services. The kinds of clients that they were supporting and continue to support have comorbidities, are living with dementia, recovering from surgery, or at the end of their life. And one of the really characteristic features of the Buurtzorg model is that the care teams are self-managing. They're non-hierarchical. They're supported by a coach and a back office, but all the management happens within the team among the nurses themselves. A review of this model of care by KPMG in 2015 found that there were really high levels of staff and patient and client satisfaction by comparison to equivalent services, and that costs were at most about average. There are now some 800 to 900 Buurtzorg teams across the Netherlands, and Jos de Blok's been really active in promoting this model internationally. The West Suffolk test and learn came about when a host of local health and local authority organisations moved into an office building and shared the third floor, and they launched a relationship building project, the third floor project, and chose a topic which was how can we support older people to sustain their independence after leaving hospital. They had some seed money from local transformation awards, and by 2017 they'd used a human-centred design approach to identify Buurtzorg as a promising model and decided to come together and launch a test. So the partners were local councils, the Clinical Commissioning Group and the West Suffolk NHS Foundation Trust, as well as the local government association. They agreed to co-fund the test. It would double run with other services and it would run for 12 months. So we were commissioned by the East of England LGA to provide a record of what was established, focus on staff experience in the test. There was a parallel review commissioned by the local Health Watch organisation to interview patient and carers about their experiences of the service. And the LGA and our organisation were also interested in understanding, does this look like a model which looks promising for this context? So we used in-depth interviews at 2 time points, at the beginning and the end of the test, with all the nurses and the managers closely involved. We facilitated and observed a half-day workshop at a midpoint between those interviews with the nurses and the managers. We also drew on management documents, bi-monthly telephone catch-ups and basic activity data collected by the test itself. So what did we find? Well, they did set up a nursing care team, the neighbourhood nursing and care team as they were known, which at its highest number had 6 members, nurses and assistant practitioners. They were working non-hierarchically and they were supported by a coach and a clinical lead. They selected a village and provided care in that village. They did it out of a base in the local GP practice, and they were receiving referrals from those GPs, also from district nurses, local community leaders and individuals re-referring themselves into the test who'd been cared for earlier. In terms of clinical care, the types of care that the team were providing were similar to the less complex end of the care provided by district nursing teams. So wound care, medicines monitoring and administration, blood tests, palliative care. They were also in social care terms providing some very limited personal care, so support with washing, eating, dressing, and some wider social care support and a reablement support. So a lot about mobilising people outside of the house, reconnecting them with social networks, as well as, for example, support with applying for benefits. They had a very small caseload, so roughly one staff member for every 3 patients or clients. So what went well? Well, the care was the major achievement in this test. Nurses talked about the profound benefits of having the time, the mandate and the flexibility to really sit and listen to people, build rapport with them, have conversations with them, understand what was happening for them, and then to work flexibly around their needs to support them to regain their independence. That was profoundly rewarding for the nurses. They were able to see the benefit of that care that they were providing. They talked about reconnecting with their vocation, by contrast usually to past nursing posts where they felt like they could see some of what was needed but weren't able to provide sufficient support in the time that they had available and the restrictions placed on them. So one nurse said, "I wish every nurse in England could get an opportunity to work in this way." And we did hear many stories about the difference that this intense and flexible input made for the people who were being cared for. For example, a bilateral amputee with mental health problems was referred by the district nurses, and with intense early input was supported to mobilise outside the house, to regain social networks and independence and a much better quality of life. The Health Watch evaluation produced some great stories about the benefits to patients and carers and clients. The challenge that we have with the data is that the data we've heard and the data they've collected is not random. So we don't have representative data. So we know some excellent care was taking place, but we don't know whether it was consistent across the test. The test was really beset by challenges. I think foremost was around working non-hierarchically and self-managing, and doing that at the same time as having to establish the infrastructure for this service. So the nurses who joined this test, most of them didn't have management and leadership experience. Many of them weren't very motivated to engage in self-management, to establish a service. Their focus was around being able to care flexibly for the people that they were looking after. They didn't have sufficient support and training around self-management, and so lots of tensions arose in the team. People really struggled with this, and the local managers involved had very laudably tried to stick to the spirit and the principles of the Buurtzorg model right from the outset, and to leave important decisions about the service and how it should be set up to the nursing and care team. But this was experienced as pressure by the nursing and care team, who felt they weren't adequately resourced to make those decisions. So that was a real challenge. Related to this, there was a real issue around staff recruitment and retention in the test. So some of this is a national problem. We have a national workforce crisis in terms of nursing. In this context, the test really struggled to recruit nurses with the right community experience and the right management and leadership experience, or at least motivations. And it was very difficult to retain staff, partly because of the challenges around self-management and the pressure that they felt. So by the end of the test, there were only 2 members of staff remaining. The third main challenge was around bringing social care alive within the test. And again, this was for a number of different reasons. One was a very practical one around struggling to have enough staff to staff a rota to meet personal care needs, which might often involve 3 times a day visits, for example. So that was a really practical reason why the team never took on full responsibility for all the personal care needs of any of their patient clients. But there was also a challenge around an understanding of what it meant to take on those social care needs. So there were different understandings of what social care should look like and involve, even within people working within the local authority in the test, and certainly between them and people working in the health organisations and the nursing and care team themselves. So I remember in the workshop, a nurse said, well, I think I'm doing social care to a social manager, but you probably wouldn't call it that. So was it a set of skills? Was it a mindset? Was it a kind of support? And what should that look like? Challenges around how you would charge clients for that aspect of that care were also not resolved in this time period. In the end, the team and the managers decided to focus on the re-ablement aspect of social care, which would anyway be provided for free to people. So what did we take from this? Well, as this test was going on, Matt Hancock, Secretary of State for Health and Social Care, who is also the MP for that constituency, had visited the test and was extremely excited by it and said in a number of conference speeches afterwards, we want to see this grow. What did we take about whether this model works well in this context? Well, number one, reinforcing what we know from the literature on policy translation and on innovation and spread. Can't cut and paste a model from one context to another and expect it to achieve the same results. You need to recognise that the work of adaptation is really the work of creation, and it involves lots of skill and time and input. Number two, there was a real tension between performing and learning, a pressure to quickly show results, for example, reducing hospital admissions in a very short amount of time in order to secure future support and funding for this way of working on the one hand, and on the other a real commitment to learn and to act on that learning, which would take a much longer period of time. So these sorts of transformations require years and years and protection, not months, and a requirement to demonstrate improvement. And finally, staff autonomy we could see was so important to the great elements of care that were able to be provided in this model, but that any commitment to self-management on a grander scale needs to be taken slowly and to be built up with the skills and the motivations and the interests of staff involved. So thank you very much for listening. Please do comment and ask questions. Here's links to our report and a blog on the learning that we took from this work. Thank you.